Myself, Dr. Kaveri Kiran Shinde. I welcome you all on behalf of Shree Saptashrungi Ayurved College and Hospital, Nashik. Friends, as we all know that many new diseases are coming up with many new clinical manifestations, new clinical variants, and many new symptoms and signs. It becomes very difficult for a physician or a gynecologist or a surgeon to come up with a perfect diagnosis. So at such times, if we take help of the radiological findings or if we blend our clinical knowledge with the radiological findings, we can come up with a good diagnosis so that we can give a good treatment to the patients. Today, we have a renowned radiologist of Nashik city with us, Dr. HARSHAL BADGUJAR sir. He is going to share his valuable knowledge and information in the field of radiology with us. Sir has done his MBBS from BJ Medical College, Pune, and then Sir has studied MD Radiology from Sion Hospital, Mumbai. Now currently he's working at Synapse Scan Center, which is at Dindori Road, Nashik. So after the session, if anybody has queries regarding the session or regarding the radiology, you can feel freely to ask sir, but after the session, or you can just message in the chat box also. So I welcome you, sir. I request him to continue the session.
Thank you so much, ma'am, for my kind introduction. Now, I guess we should fastly start the session directly. So, let's start with the session. So, today is the role of radiology in diagnosis. So, I will cover. Hello, my voice is audible, right?
Yes, sir. Yes, sir. Audible.
Okay. So let's start. So I will this today's lecture is actually a mixed bag. So I will use both languages, Marathi as well as English, in today's session. So let's start. What is radiology? So radiology is a branch of medicine that deals with radiant energy in diagnosis and treatment using imaging technologies. So there are two broad areas. If we can divide radiology in diagnostic radiology and interventional radiology. So let's start with diagnostic radiology. Diagnostic radiologists use medical images such as X-rays, ultrasound, CT, and MRI scan to diagnose the disease. It's basically imaging to diagnose a particular disease. Then in diagnostic radiology, there are various subdivisions, as we can say, like neuroradiology to image the brain and central nervous system, pediatric, breast, cardiology, chest, gastrointestinal, genitourinary, musculoskeletal, emergency radiology, and the nuclear radiology. So these are all the subdivisions of diagnostic radiology, which are kind of subspecializations of it. So in interventional radiology, intervention is basically to intervene the disease process using the imaging facilities we have. So it's basically in a simple language, we can say it's a image guided treatment of disease. Interventional radiology is basically not the diagnosis, it's after the diagnosis, it's the intervention of the disease process by the radiological imaging. So it's actually a minimally invasive intervention techniques. That's what we use. It's not a proper surgical techniques. That's what we do in normal surgeries. We take a cut and then after that we stitch it. It's actually in interventional radiology we usually take a access through a needle and through which we do the intervention. So what all is included in interventional radiology? So basically the angiography, the blood vessels. So the major part of interventional radiology deals with vascular diseases, any occlusion, any emboli. So we can actually take a vascular access and through image guided intervention we can actually clear the obstruction by interventional techniques. So then comes the biopsy procedures. So various biopsy we require. So we can take the help of image guiding, either USG or fluoroscopy in these techniques. So we can do angioplasty as well. So balloon dilatation of vessels is under that only. We can use stents through these techniques. So fluid abscess drainage are the other applications of interventional radiology. So then comes the nuclear medicine. So I am actually like prepping you the basic terminologies, so how the division is there in diagnosing. So next time when you come across these terms, you can accurately like look at it in a correct way, ki what it deals with, the whatever the terms you have come across. So in nuclear medicine, we use the small amounts of radioactive material to diagnose and determine the diseases. So most of the nuclear medicine is dealing with cancer. So now many types of cancer, heart diseases, gastrointestinal, endocrine and neurological disorders we can see with nuclear medicine. So there are few modalities like PET, you must have heard, or SPECT, that deals with nuclear medicine. So there are basically two kinds of images, we can say, the structural and anatomical information. The CT, MRI, ultrasound we get, with each elemental volume, tissue differentiating properties are measured in structural imaging. And the other is the SPECT CT or PET CT. That's what is the called functional imaging. So it's actually in PET we actually look at the functional status of this tissue rather than just the structure. So in basic radiographic techniques, we can see how the tissue is there, the structure wise. And in the functional imaging, the nuclear imaging we discuss, SPECT and PET, we can actually see the functional status of that tissue. So that is what the basic difference is between structural and functional imaging is. So we will look at in short radiological modalities. So plain film radiography, we will first start with basic X-ray, the plain film radiography. So in medical X-rays, these are five different radio densities are there. So density can be from least to the most. So air is dark and the metal, which is the densest material, is the brightest. And in between them, the medium or the other shades of gray will appear for fat, soft tissue, or the bone. So this is how the basic is works in radiography. It is actually according to the density difference of the material we are viewing, we get the different shades of gray in the film. So this is how the chest radiograph PA view normal looks like. So in this, obviously the lung has air, so it looks black between the ribs, which are bit dense, that's on whiter side. And obviously the bones, all other bones as well, clavicle and spine, which are seen posteriorly, which are more white. And other soft tissues like heart, this shadow is seen, or other soft tissue shadows are in between white and the black, which are the shades of gray. That's what we are seeing. So there are various projections we use in chest X-rays. You must have many times seen the PA view chest X-ray or AP view. So most of the time we do PA view chest X-ray. So it actually the PA or AP, it depends on the location of X-ray tube and X-ray film in relation to patient's anatomy. For example, now in PA view, the most commonly done X-ray view in chest, it means the beams are traveling from back to the front of the patient and hit the patient in front. So these are the basic difference between PA and AP view. So PA, this is the PA view chest X-ray, and lower side is the AP view chest X-ray. So looks the same, but there is a subtle difference. If you see, heart size here it's smaller. In AP view, heart as is located anteriorly, and the direction of X-rays is from front to back, so that heart shadow is little bit bigger. So this is the same patient's X-ray in which heart looks bigger in AP view. So this is the basic difference between PA and AP view. So there is something you must have heard, portable radiography. So when the patient is too sick to leave the bed, we use the portable radiographic machines for that. Supposedly in ICU, injured or trauma patient. So there are few disadvantage of portable radiograph that we do. There is a different magnification, so distortion of size of organ, as we have seen in AP view in previous image. So size of the organ is falsely put as the different from normal. So usually it's done in AP projection. As you can see in bedridden patient, we cannot make them stand and take PA view of chest X-ray. So usually bedridden patient we do AP view of chest X-ray, which is still different. Other few modalities we can use, like this is the knee X-ray. We can see this is actually a weight bearing radiograph we usually do in knee. So we put a stress on is a patient's own weight is the stress on specific organ, usually joint, for example acromioclavicular joint, knee. Okay, so this is the knee X-ray, standing weight bearing. So that we can actually see what is the joint space reduction in this case on weight bearing situation. So weight bearing gives you more specificity of diagnosis. For example, in osteoarthritis of knee joint, pneumothorax on left side. We will see now another X-ray. This is actually a classical COVID. Bowel looks okay. In this case, this is large bowel shadow, which is okay. But this small bowel loops are hugely dilated. So this is a case of small bowel obstruction. Now we have seen the knee radiograph as previously. Now see, this is normal knee joint space. How it looks like the black area between the femur above and tibia. Hello, Ye- yes, yes. Mhm. Yes, yes. एक्सरेच्या सेकंड स्लाइड पासून इमेजेसच्या. येस येस, शुअर शुअर. आता आता येतोय आवाज, कनेक्टिव्हिटी आहे. येस येस. ओके. So I am repeating few slides here. I guess connection problem was there. So as we have seen, this is a case of air under diaphragm. Then this is a case of pneumothorax. We can easily see here the pleural space which is filled with the air here, and there are no bronchovascular markings in on left side. However, on the right side we see normal bronchovascular markings with there are additional findings like due to tension pneumothorax built on the left side, there is a shift of mediastinum to the opposite side on the right side. So we can see the trachea which is deviated to the right side, and also the heart which is seems to be deviating to right side. So this is a classical case of pneumothorax. Then we see this is a case of COVID. The bronchovascular markings, as you can see here, are more prominent, and the patchy opacities which are seen here, which are obviously not normal. So this is a case of severe COVID. We can easily spot the difference, as we can see the normal markings here, and these are abnormal prominent markings, and the shadows we can see here. So this is actually a case of COVID. Chest X-ray. So this is another radiograph of abdomen showing dilated small bowel loop. These are actually the jejunal loops which are hugely dilated. We normally don't see like this, and this is actually a fundic stomach shadow. Then the large bowel loops here at the periphery of the abdomen are okay, but this center of the abdomen small bowel loops are hugely dilated. So this is actually a case of acute small bowel obstruction. Then this is a knee radiograph. See, this is a normal joint space. That's what we can see. Normal. This is a femur above, tibia and fibula. So this is a knee joint in a normal case. So normal knee joint space is maintained here. See, this is a case of severe arthritis. Now the joint space reduction is there. There is no black area, which is normally the normal joint space we can see here. Sorry. So this is a case of severe osteoarthritis of the knee. There is severe joint space reduction. There are other findings also. We can see the regularity of the cortical margin here. So there is obviously the loss of regularity of cortical margins are seen here. The osteophytes are seen from both femur and tibia, as well as subchondral sclerosis. If you can spot these white lines which are seen running under the articular surface, is actually a articular sclerosis due to chronic joint space reduction, in this case of osteoarthritis. So this is a case of osteoarthritis of the knee joint. Then we come across few other modalities. So this is actually a fluoroscopy machine we can see here. So what is fluoroscopy? You must have come across this word. Fluoroscopy is actually a type of medical imaging that shows a continuous X-ray image on the monitor, like an X-ray movie. So actually, it's a X-ray image only, which shows a continuous monitoring of the uh, part of the organ we are viewing. So X-ray is a spot film. That's what we take. But in fluoroscopy, there is a continuous imaging of the patient's body can be done. So during fluoroscopy, what we do is an X-ray beam is passed through body, image transmitted to monitor. So movement of part of body or instrument or contrast can be done through detail. So it's actually a dynamic thing. If you uh, see in the basic, fluoroscopy is actually a dynamic X-ray image. That's what it is, nothing else. So what where we require fluoroscopy? So in case of barium swallow, you must have heard, for esophagus, we do dynamic swallow studies so that we can actually spot are there any movement abnormalities of esophagus. So these are actually various barium swallow images of esophagus we can see here. So these are normal images, and a few of this is actually a case of CA esophagus. We can see this is a barium column. We see in a lateral fluoroscopy image. These are vertebrae. Behind this is lateral esophagus view. We can see there is a stricture here in the middle of esophagus. We see the normal barium column above and below it. So this is actually a case of CA esophagus. So we can actually dynamically see in fluoroscopy how the contrast which is used as barium, which is going through esophagus in fluoroscopy. So this is in short about fluoroscopy. Then there is this word you must have heard, hybrid cath lab. You must have heard many hospitals have cath labs in them. So what is cath lab? So actually hybrid cath labs provide advanced imaging at the same time fulfilling the requirements of treating complex cases like high risk patients and structural heart diseases. So it's actually imaging plus treatment at same place. You image the dynamically the organs or structures, and you treat it at the same time. That's what there is in cath lab. So next generation cath labs are ideally suited for performing new therapeutic procedures such as aortic wall replacement, mitral wall repairs, and epicardial ablation of ventricular tachycardia. So they improve the quality and cost effectiveness of patient care by expanding room capabilities and broadening the procedure mix. So this is actually a image of a hybrid cath lab. You can see this large machine on the left side of the image. This is actually a fluoroscopy type of machine. Yeah, it is a dynamic X-ray machine. So and it also is USG machine. Then it also has a normal surgery OT like light. So this is actually hybrid cath lab is basically a space where you can dynamically image the patients what's happening and treat simultaneously. So cath labs can be used in few situations, like in interventional radiology we can use cath lab, so we can actually image in fluoroscopy and treat it at the same time through the vascular access. So this is what in short about cath lab is there. So we will directly now see about CT angiography, because last time in the lecture I have covered the basics of CT. So today we are actually later on, as you will come across, we will see the imaging of a stroke. So in CT angiography, the what we do is scan IV contrast is used. So scanning when the IV contrast bolus reaches its peak in the vascular structures being studied, either arterial or venous. So there are two basic types of angiography. You must have come across this word angiography. So angiography can be CT angiography or your conventional catheter angiography. So actually CT angiography is a kind of less invasive technique of doing angiography. Angiography is basically imaging blood vessels. Angio is a blood vessel, graphy is imaging. So imaging blood vessels can be done by CT or the conventional angiography. That's what we do in cardiac angiography. We use catheter and then we push the IV contrast material and image it through fluoroscopy. So, so this is the basic CT angiography reconstructed image. So there are few technical points to be considered in CT angiography. The CT machines we are using for doing angiography, they should be faster. Basically, the multi-slice CT is needed. So there is few technical differences between conventional angiography and CT angiography. So obviously there will be no placement of angiographic catheter. So CT is obviously the non-invasive way of doing angiography. So there are few differences. You can not do angioplasty or stent placement as you can do in conventional angiography. So this is a basic CT angiography image you can see in brain. These are basic angiography images. This is in coronal section, this is in sagittal section. So there are various applications of angiography. The blood vessel related abnormalities we can see, aneurysms, AVM, atherosclerosis, we can easily spot through angiography, which we cannot see on plain scan. So angiography, this is basically the white vessels which we are seeing. These are contrast filled vessels, which are seen in angiography. So there are few images here. I've shared. This is actually A on the left side. This is conventional angiography image. This B is actually a CT angiography image of brain. So we can see how detailed the image looks like in catheter angiography. The small vessels we can easily spot. The arrow is to the actually a small stenosis of the vessel. It is actually ICA, and these are small blood vessels of brain. We can easily spot the minute occlusions on catheter angiography. Whereas in CT angiography, we can still see it, but there is surrounding brain parenchyma as well. So there is surrounding noise as well in CT angiography. So this is actually basic image differences how we see in conventional versus CT angiography. So these are another picture of conventional angiography. On left side, how beautifully we can see the small images up till their ends in conventional angiography. That the catheter angiography we know the invasive technique, and this is the CT angiography image, again non-invasive, but we can still see vessels, but smaller vessels are a bit less clearly seen compared to conventional angiography. So this is what the basic difference is. So MRI I will introduce in short. Now MRI actually uses strong magnetic field and radio waves to create detailed image of organs. So so there are few basic differences between MRI and CT scan. So MRI scan differs from CT and X-rays because it does not use ionizing radiation that can be potentially harmful to the patient. So MRI scan we can do on a pregnant patient, but CT we obviously cannot do so because it uses X-ray which are harmful to the fetus. So I will introduce you to basic differences between CT and MRI scan. So CT is best suited for viewing bone injuries, diagnosing lung and chest problems, and detecting cancer. So MRI is suited for examining soft tissues in ligaments and tendon injuries, cord injuries, and brain tumors. So CT scan is widely used in emergency room because it takes fewer than 5 minutes. MRI, on the other hand, can take up to 30 minutes. So these are few basic differences. Timing, costing is also a difference. MRI typically costs more than CT because it's heavy on maintenance. So one advantage of MRI, obviously, I told you, it does not use radiation while CT scans do. So the radiation is harmful when there is repeated exposure in CT scan. So these are a few basic differences between CT and MRI. CT is faster, MRI takes a bit longer time, but MRI has more accuracy and better imaging quality in case of soft tissue injuries. So this is the another part of our lecture in which we will see imaging in cerebral ischemia and hemorrhage. So as I know, the viewing people today are medicine related. So you must be seeing cerebral ischemia, that is stroke, in your practice quite commonly. So this is one modality which is heavily dependent on the radiological imaging. So ischemia and infarction, I will like shortly put up the basic differences between them. So in ischemia, the affected tissue remain viable although blood flow is inadequate to sustain normal cellular function. While in infarction, frank cell death occurs with loss of neurons, glia, or both. So infarction is actually a next stage of ischemia in which infarction becomes irreversible cell death. Ischemia is still a compromise in blood supply, but still the tissue is viable. So that's the basic difference between ischemia and infarction. So, to define stroke, what is stroke? Stroke is classically characterized as a neurological deficit lasting more than 24 hours attributed to acute focal injury of central nervous system by vascular cause. So, basically, a vessel occlusion or vascular cause will cause a neurological deficit which will last more than 24 hours. Then we will call it as a stroke. So 80% of stroke cases are related to arterial ischemia or infarction, and other 20% are related to the hemorrhage. That's what we call brain hemorrhage or spontaneous intracranial hemorrhage, or another causes like non-traumatic subarachnoid hemorrhage or venous occlusion. So these are the remaining 20% of stroke cases we see. Then in stroke, there are a few phases like hyperacute in less than 12 hours, acute uh, 12 hours to 2 days, subacute 2 days to 2 weeks, chronic after 2 weeks. So actually differentiating these stages by radiological imaging is quite important, because actually if we see stroke or the brain, basically brain is all about time. So the treatment highly differs according to the time from the injury has occurred. Supposedly, the treatment of hyperacute stroke is totally different from even the acute stroke. So, radiological imaging help us to identify the what is the stage of the brain tissue in which it is, so that we can appropriately plan the management according to the stage of the injury we see in the imaging. So this is basic pathophysiology. I will introduce you what happens in stroke. Actually, there is there is reduced blood flow in minutes. What happens is there is functional loss of cell. Then there is cytotoxic edema or cell death in 12 to 24 hours. Then there is increased water content, vasogenic edema, mass effect in 12 to 12 hours to 2 weeks. Then there is finally gliosis. So this is what the sequence of events that happens in a case of stroke. So role of imaging in stroke. So what is the basic role is there? So rule out hemorrhage. Hemorrhage, we can easily spot hemorrhage on imaging. So we can do that. Then obviously the therapeutic role, which is highly dependent on the timing of stroke. So how much time that has passed from the stroke that has occurred. Therapeutic treatment widely varies with it. So hyperacute stroke is less than 6 hours. Acute infarct is 6 to 24 hours. So these are few images of CT I am sharing in case of acute stroke. It's a blunting of right lentiform nucleus. If we can spot, there is a subtle difference. This is a case of actually acute stroke. This is a basal ganglia region of right side. If you can see, there is loss of differentiation. There is comparison on left side. If you can see, there is a subtle differentiation between the basal ganglia on the left side. So on the right side, there is a obscuration. This is bit difficult to spot here easily, but this is what acute stroke looks like, how subtle it is on CT. So there are other few signs like dense MCA sign. We can see this is a middle cerebral artery which look denser on left side than on the right side. So this is a case of acute stroke. Acute infarct in right frontal region. We can see this is a hypodense area here in the right frontal region. We can spot here, which is relatively different in density from the surrounding brain parenchyma. So this is actually a case of acute stroke. Then DWI in stroke. This is really important and new thing. Now, what is DWI? DWI is actually diffusion weighted imaging. Diffusion weighted imaging is like nothing but is a type of MRI imaging only, but it is really important in hyperacute stroke. Hyperacute stroke, as I told you, is a state less than 6 hours. So in the first stage, there is cytotoxic edema. So cytotoxic edema we can actually only spot through DWI imaging in less than 6 hours. So in DWI, what is its importance? DWI has 100% sensitivity to stroke within minutes. So most sensitive technique of all for hyperacute stroke is an essential part of MR evaluation of penumbra. Penumbra is actually a word to evaluate, is actually a viable tissue which is still survivable in infarct. So it is like penumbra is a, we can call it a ischemic tissue, to differentiate ischemic tissue from infarcted tissue which has permanent cell death. We can actually save this tissue which is ischemic by uh, re-establishing the circulation. So in DWI, I will directly show you images. So these are actually DWI MRI images. You can easily see the bright areas are actually the infarcted areas. You can see these are in C image, these are embolic small infarct. In A image, these are lobar infarcts. We can see as bright images. So this is actually are cases of hyperacute infarct which have easily been spotted on MRI. In CT, this is a bit difficult. Now, sorry. So see, these are this is a CT image. On A left side is a CT image, and B this is a TWI MRI image. So in CT look absolutely normal. So this is actually a case of hyperacute infarct, less than 6 hours. So less than 6 hours is actually a very important time, because in this situation there is actually a tissue of brain which can be viable and which can be saved by if the recirculation of occluded vessel is established. So this CT scan on left side absolutely looking normal. So someone would say this is normal, no infarction, but this is actually a case of hyperacute infarct. If we see DWI image in MRI, the the bright area here is a case of acute infarct. So this is what the value of DWI MRI is. This is another now comparison between MRI and CT in case of acute stroke. So after 55 minutes, immediately after the stroke, see in DWI there is a bright area here on the right side. CT absolutely normal. Even this is third is the MRI non-DWI image. This is T2 weighted MRI image, the third one we see, which also is normal. So DWI only picks up the hyperacute stroke here. CT being normal. So then after 5 hours, still CT is normal here. If you see this bright pointed spot, this is again a case of hyperacute infarct in which CT also is still normal after 5 hours. In the third image, the T2 weighted MRI image, there is a slight subtle brightness which we can see beside the ventricle here. So this is what the value of DWI is, and when you should do DWI. So CT is okay, but CT actually shows your infarct after 6 to 8 hours, which is quite a late time to re-establish the circulation of injured brain parenchyma. So DWI MRI imaging is fast within 15 minutes, and we can spot the acute stroke by DWI MRI imaging. So this was about DWI imaging. So subacute stroke is between 1 to 8 weeks. It's the next stage after acute stage. So these are few images I have for subacute infarct. This is left frontal region, which is more now blacker than the surrounding parenchyma. This is a case of subacute infarct, if you can see. Then chronic stage is 1 to 2 years post infarction encephalomalacia occurs. So this is a case of chronic infarct. In the right parietal region, you can see it's almost like CSF. These are actually ventricles. If we can see brain axial section, this is a large infarct which is chronic, almost as black as CSF. So blacker the infarct looks, the more the age of infarct is. If you can remember it shortly. So more subtle the infarct is, more acute it is, and more prominent it looks, like more blacker side it is, more chronic it is on CT. This is easily you can see this is a chronic infarct in left frontal region. There is a ventricular dilatation due to encephalomalacia. So this is a case of chronic infarct which looks absolutely black. Yeah, if it was acute infarct, we won't have seen this clearly in CT. So then intracerebral hemorrhage, which are the 20% cases of your stroke. These are few intracerebral hemorrhage slides I have. So bright is the actually this is a hemorrhage in the ventricle. It is the intraventricular hemorrhage which are extended from the caudate nucleus. So bright we can easily see on CT, which is very sensitive for hemorrhage. So this is a case of caudate hemorrhage. Then we have thalamic hemorrhage. This is axial section of brain. We see this bright area. This is actually a thalamic hemorrhage. This is a lobar hemorrhage, right parietal hemorrhage. We can easily spot it as a bright area. So this is a hemorrhage. So basic difference is hemorrhage will look bright and the infarct will look on the darker side on CT. MRI is totally different. This is a case of cerebral hemorrhage. We can spot this subtle hemorrhage here on the right cerebral hemisphere. So this was about stroke. Now we will move on to another modality, which is USG, in which I will directly jump to something called as FAST, which is important. What is FAST? FAST is actually a focus assessment sonography for trauma. So we come across very this emergency patient. So this is a case. Now we'll take a situation. This 29-year-old male hit by a car. He has a BP which is obviously on lower side, 70-20 pulse rate increase. So we can see this is RR is also increased. So this is a case of hypovolemia. He must be losing blood from somewhere. So where from it is? We can do the FAST, which is a USG technique basically to detect the bleeding that has occurred in abdomen. So this is the image in the trauma situation. Someone emergency physician is doing a USG here. So this is what the next of USG is, the portable USG. You can see on a small phone like thing there is USG image which is being seen. It is still not in India due to PNDT issues, but in other countries it's already there, the portable USG machines. So this fast scanning as we have seen in USG. So these are the few areas which we scan in FAST, which is focus assessment with sonography in trauma. So these are the few marked areas which we see for. This is liver side, this is epigastrium, this is spleen side, and these are another E fast. We do extended fast for blood in the pleural cavity like hemothorax or pneumothorax even we can detect in fast. So this is a diagrammatic representation of how the in trauma if bleeding has occurred, it will collect in dependent position. So there are two pouches in peritoneal cavity. One is hepatorenal pouch, also called as Morrison pouch, and other is rectovesical pouch. So these are the most dependent areas in which blood will first collect. So we can easily spot the blood in these areas using USG and direct the next patient treatment. So this is actually a USG fast image. This is kidney. You can see the reniform shape around the kidney. This black area. This is actually a fluid collection. So this is nothing but the fluid blood in Morrison pouch. So this patient will obviously need urgent laparotomy to see the bleeding site and seal that. So this is how the USG in emergency trauma situation work. That's what we call as fast. Then other modality I will shortly introduce you, PET, that is positron emission tomography. PET we actually use some tracers which are radioactive tracers, and we spot the activity of those tracers in diseased areas. So in diseased areas actually we'll have more uptake of these tracers, because in tracer what we use is we use glucose. So glucose consumption obviously will be increased in the cancerous tissues. So the basic idea behind using this FDG, that's what we call in PET, is that we use the tracer attached with the glucose which is radioactive. So those tracers are concentrated in the malignant tissues which have more metabolism, which we can easily spot as bright spots in in the PET scan. So this is basic about PET scan. What we use, the tracer which has glucose linked to it. So increase metabolic activity by cancer tissue, increase uptake, we can easily spot as bright areas on PET. So this is what PET is. PET obviously has many applications, like detect the stage of cancer earlier than CT or MRI. Because as I have already told you in starting, PET is a functional is a functional imaging modality. CTMR is structural imaging modality. So the functional, the metabolism of the cancerous tissue is already increased far more earlier than what we can detect on CT or MRI. So early stages of cancer we can detect through PET scanning, and that determine whether cancer has spread throughout the body, the metastasis, because it scans the whole body metabolism. So we can easily spot the areas where metabolism and increase. Metabolism is increased and suspected metastatic focus. We can easily look in PET scans. So these are some of the few other applications of PET they have listed after recurrence of treatment. So, to say in short, PET scanning is basically for malignancy screening, detection, and follow. So I think I have taken a lot of your time. So this is time to end our session. So thank you so much for patiently listening my this kind of lecture, which was kind of haphazard, which was not one to the point, but it I guess it covered the many basic situations of medical imaging we come across, like the emergency, that's what I have covered. The fast, then the stroke situation, which usually come in the casualty cases. So this was my few basic points about radiology and medical imaging. So thank you so much for patiently listening to me. Thank you so much.
Yes, it was really a very wonderful session and useful too. I think the basic concepts of many of us are clear today. This will surely help us in cancer department of our college and hospital. I also thank our founder chairman, Honorable Dr. Saheb Ahir sir, our chairman Himgauri Ahir Radke madam, and our principal Dr. Milind Davare sir for giving us opportunity to arrange such a useful session today. I also thank the members of our technical team of our institute so that we could conduct such a nice session online successfully. So I again thank you, sir. Um, with this, I declare that the session is over.
Great. Thank you so much.
Thank you.